All right, everyone. We're a few minutes in, so we're going to go ahead and get started. Welcome to our webinar on strengthening the health workforce of the future, charting a vision for evidence-based impactful learning and performance. My name is Julia Bluestone. I'm a senior capacity building advisor for the Momentum Country and Global Leadership Project and the technical director for learning and performance at JPIGO. Next slide. What we're going to do today during our webinar is we'll have brief opening remarks from Erin Smith from USAID, and then I will do a framing presentation that will share results from a Gavi, a Global Vaccine Alliance funded situational analysis of efforts to improve health worker learning and performance that was completed in 2022. Then we have a fireside chat where we will hear from 3 different Momentum country projects, how they are helping the countries they support integrate more impactful evidence-based approaches for helping improve health worker learning and performance. And we'll take questions and answers, and closing remarks will be made by Koki Agarwal, the Momentum Country and Global Leadership Project Director and Vice President for JPIGO's Washington, D.C. office. It's a tight agenda, so please do chat in questions you have as you have them, and we will do our best to respond to them either in the chat or during the Q&A. So next slide, I'm going to hand it over to Erin Smith. Erin Smith is the acting AOR for Momentum Country and Global Leadership, and she's going to start us off. Go ahead, Erin.
Good morning, everybody. Thank you so much for the invitation. It's such a pleasure to be able to join you guys and to start this meeting off. USAID has a long history and deep commitment to advancing evidence-based practices, and this commitment is reflected in Momentum projects around the world and the work that you do every day. Momentum works alongside governments, local and international, private and civil society organizations, and other stakeholders to accelerate improvements in maternal, newborn, and child health services, with significant investments in working alongside governments to build health worker capacity when needed. We'll be hearing from 2 Momentum projects today: Momentum Country and Global Leadership and Momentum Private Healthcare Delivery. Healthcare workers are the backbone of the health system, and investing in their capacity and ongoing professional development is critical. Today, we are excited to hear results from a global situational analysis on the current and future state of healthcare worker capacity building, with a focus on health worker and stakeholder perspectives. More importantly, we will hear practical experiences from 3 countries working alongside governments and private sector to expand use of evidence-based capacity building practices for better maternal, newborn, and child health outcomes. I look forward to hearing about the project experience, and hand it back over to you, Julia. Thanks.
Thanks so much for doing that, Erin. If you could pull up the slide deck again. So I'm going to start with a brief presentation to share some of the highlights from the situational analysis completed in 2022, with a focus on sharing with you what we heard from health workers, what we heard from stakeholders, and what are promising approaches that Gavi Alliance partners are interested in expanding the use of. So next slide. Why does this matter? This matters because Gavi, or the Global Vaccine Alliance, recognized that they're spending across the alliance partners millions of dollars, heavily investing in one-time in-service training, often residential and supportive supervision, without seeing the desired impact they want to see in health worker practice outcomes or even client health outcomes. For example, from 2018 to 2020, the Global Fund alone invested $520 million primarily in in-service training and supportive supervision. So across the alliance, they're recognizing we can't continue to invest so heavily in these approaches. So that's why that matters to us. Before I jump into the presentation, we want to run a very short poll just to gauge what's happening in your countries. So we'd like you to answer these poll questions based on the countries either that you are working from or countries that you support. So please go ahead and take a minute to respond to this poll and just these 2 questions to see what's happening in the countries where you are now. Okay, great. So it's interesting to see, at least we've got over 100 folks on the call, like almost half, are working in countries where it is a priority to move beyond relying so heavily on these two approaches solely. And there's an interesting mix of where countries are in prioritizing the integration of technology, which was a focus of this situational analysis in part, but we're not going to spend too much time on that today. Thanks. Go ahead. You can close the poll. It's great to see what's happening at the country level now. So I'm going to jump into the presentation because my time is tight. Please do chat in questions that you have, and we'll also share the link to Gavi's website where they've highlighted some of the assets from this work. So in 2022, JPIGO had a contract to complete a situational analysis of the current state of health worker learning and performance and the desired future state, and to map the health worker learning journey. And I was the project director for that project, which is why I'm presenting today. Next slide. On the screen, you can see the situational analysis process that we used, and I'm not going to read through everything on the slide, but there's a few things I'd like to highlight for you. One is this whole process was led and really governed by a very active alliance member working group from Gavi that included representatives from WHO, Bill and Melinda Gates Foundation, the Global Fund, World Bank, UNICEF, and CDC. So we had a very active alliance working group that we met with on a regular basis who really steered the direction that this took. The other thing I'd like to highlight is, even though this was a very small scope, I would say, situational analysis, we did go in depth in the countries that we looked at. So we did a desk review, which focused on systematic literature reviews or meta-analysis and strategic documents from ministries of health or alliance partners to look at the current state and desired future trends for learning and performance efforts to improve health worker performance. And then we did key informant interviews with the Alliance working group members, as well as with representatives either from the national EPI programs or from the Human Resources for Health or in-service training divisions within 7 countries that spread across Gavi different portfolios, from fragile states to more advanced state countries. And then we did human-centered design meetings in 3 countries with health workers primarily involved in immunization, so professional cadres, nurses, clinical officers, midwives, to investigate what is their current learning journey, what does that look like, and what are those preferences. So this is the process that we used. Next slide. I want to start by highlighting for you what we heard from health workers. So we did focus on professional paid health workers because a big piece of how countries invest in improving learning and performance are continued professional development systems. So we wanted to work within cadres that had that mandate. So the goals of these meetings are listed here, and I'm not going to go into the details, but I'm going to jump right to focusing on what we heard from health workers about their learning journey. What does their learning journey look like? And what are the facilitators and blockers that allow them to engage in digitally supported learning and performance approaches? Later, when we talk about promising approaches that we want to increase the use of, then I'll highlight what we heard health workers wanted. So next slide. So first on this slide is a mapping of what we heard from these almost 60 health workers, what their learning journey looks like. I'm not going to read everything on this slide, but a few important things we wanted to highlight and is immediately after graduation or licensure, there's typically long gaps in deployment, often up to a year, where health workers have no ability to maintain their competency unless they seek like special internships. During their active practice, their access to learning opportunities is limited if they're invited to in-service training, or if they have access to digital learning, which is more and more of a priority, especially for meeting continued professional development goals. As far as performance support, they may get direct support from supervisors, but their engagement in supportive supervision visits doesn't usually result in them getting active or useful feedback. Next slide. This slide is busy, and I'm going to summarize it for you. We also mapped out what are the common facilitators and blockers. And in this case, we were speaking specifically about engaging in digitally supported learning and performance approaches, such as mobile point of care decision support tools. Like for instance, the CDC STI app is one example. The family planning MEC app would be another one, or blended learning or e-learning opportunities. When it comes to looking at facilitators and blockers, a few things I want to highlight, of course, connectivity and access. The gender digital divide is a significant barrier for women in accessing digital health supported interventions. And another thing that came out very clearly is we can't expect workers to complete learning on the job. They need to have protected time. Those are the things I wanted to highlight for you, what we heard from health workers as far as their learning journeys and facilities and blockers. And now I'm going to move to what we heard from stakeholders. So next slide. We're summarizing for you a lot of information, but for this audience in particular, because Momentum Private Healthcare Delivery is working so actively with the private sector, I'm going to bring a few things out from this slide. I'm not going to read everything that's on it. Some things I want to highlight is across the stakeholders that we spoke with in the 7 countries, every one of them said they felt private sector was important, but there wasn't one that said, oh yeah, we have a really strong strategy or way that we know we want to engage the private sector in supporting our goals around improving health worker learning and performance. So that was something that we thought was of interest to this audience. The other piece of this is continued professional development requirements we see the stakeholders see at the country level as a priority for them, and it's something that we expect is really going to increase. For instance, the last State of the World's Nursing Report asked specifically, what % of countries in Africa have requirements around continuing professional development for nurses, and the response to that was, I forget if it was 69 or 64%, but it was quite high. So we expect that component to play a more important role in the future, rather than vertical programs doing most of the driving around how we support improved health worker learning and performance. And the last thing I want to highlight on this slide is which links to CPD, is the increasing role in professional councils like boards or regulatory bodies or professional associations, like midwifery or nursing associations. Their role in either managing or providing continuing professional development is important and is only going to increase moving forward. So the next thing I'm going to touch on very briefly before I go to our panelists is what are the promising approaches based on both evidence and preferences that we want to do more of or see more of. So next slide. This is a very, oh, sorry, I'm sorry, I've missed something important. The other thing that we laid out, thanks, you can go to the next slide, we're good. The other thing that we laid out across the Alliance group, the working group, are what are the important pivots or shifts that need to be made to help transition to more impactful learning and performance approaches. So across the left-hand side of the screen, you see 5 guiding principles that we agreed to across the Alliance working group. The first is impactful, helping countries and donors shift away from being so focused on numbers towards are we getting the impact that we want? Second, country driven, really moving away from so much of the investments happening at the donor level to more co-creation, co-funding, and accountability. Third, sustainability. I think this speaks for itself, but a piece of this was looking at market shaping and what are financial levers that can be accessed, and I'm not even touching on that today. Learner-centric, being more learner-focused in co-creation or looking at learner research and how we provide individualized just-in-time learning that's more responsive to learner needs. And lastly, digitally supported, making sure that when we're selecting digital solutions, they are contextually appropriate to the digital maturity and they support evidence-based learning and performance approaches in that process. So we're going to post a link in the chat to Gavi's website where they share some of these key assets, so you can read more if you wish. So sorry, now I'll go to the next slide, please. Thanks, which is a summary of promising approaches. So Gavi and Alliance group members are asking okay, if we're not investing so much in in-service training or supportive supervision, what approaches do have evidence of impact or are preferred? So this is coded based on both a combination of strength of evidence from the desk review as well as preferences from stakeholders or end users. So collaborative quality improvement, also referred to as group problem solving, and mentorship are two approaches that have strong evidence of having impact and also were preferred by either stakeholders or frontline health workers. So frontline health workers liked mentorship, and it's also, we see it as a priority in the countries that we spoke with, as well as countries moving more aggressively into more integration of quality improvement, not focusing so much just on supportive supervision. In the middle pink, we have approaches where there's promising evidence and or it's a preference. So e-learning, there's conflicting information on whether e-learning alone impacts provider practice outcomes, but it's a key strategy for improving access to needs-driven continued professional development. So, it's a promising approach. And then at the bottom, the pale pink, are approaches where we have newer evidence or less evidence, but again, are preferred either by stakeholders or end users. So please put questions that you have in the chat, but we wanted to put in front of you what are the approaches that we're trying to use more of. So next slide. Great. So I am going to move now to the fireside chat, and I see there's some questions coming in. I'll look at those in a minute, or we'll deal with that in the Q&A. So I'm going to first introduce our speakers and thank them all for joining from everywhere that they are. And then I'm going to ask each one of them to share very briefly about what they're doing in their country, and then I'll have a few follow-up questions. So please, when you put your questions in the chat, if you want to direct it to a certain speaker, just pop that in the chat, and Koki will be managing our Q&A. So I'm going to start and read left to right, although we're going to start our fireside chat with Dr. Ope. So first, starting with Dr. Dirwani Amelia, or referred to as Dr. Lilik. So Dr. Lilik is a clinician who's been involved in maternal and newborn services in Indonesia since 1994. She's an actively practicing OBGYN. And her title is on the screen. In the interest of time, I'm not going to read people's titles. But from 2011 to 2017, Dr. Lilik, along with Budi Kamilian Health Services, led the support of clinical governance and mentorship programs in 150 hospitals and 300 puskesmas under the USAID Expanding Maternal and Newborn Survival Program. Then Dr. Ope, her title is on the slide. She is a seasoned public health professional with 16 years of experience in RMN-CAH technical assistance and leadership programs in Nigeria. She is our RMN-CAH Senior Technical Advisor supporting Momentum Country and Global Leadership Quality of Care activity in Nigeria. We have Eugenia Mensah. Eugenia's title is here. She's a midwife by profession, 10 years of clinical experience. She's currently the technical officer for family planning and reproductive health in Ghana, both for the Momentum Country and Global Leadership Project, as well as the Momentum Private Healthcare Delivery Project. And in 2019, Eugenia received the National Best Midwife Award from the Excellence Award in Ghana. Congrats, Eugenia, that's awesome. Salawatu Abdullahi has over 15 years of experience in providing technical and program oversight in the areas of sexual and reproductive health, HIV/AIDS management, social behavior change communication, and family planning. And she's joining us from Total Family Health Organization, and they'll be speaking about the same intervention together. So those are our panelists, and I'm going to jump right in with our questions. So my first question, Dr. Ope, this first question is for you. So as I mentioned, a lot of countries have relied really heavily on supportive supervision as a primary strategy for ensuring service delivery quality. And we would love to hear from you how the Momentum Country and Global Leadership Project in Nigeria is working to support expanded use of quality improvement at subnational and national levels. So go ahead, Dr. Ope. Oh, you're still muted. Sorry.
Okay.
There you are.
Sorry. So good morning, good afternoon, everyone. So for our Momentum Country Global Leadership Project in Nigeria, we're working with the national and subnational level. We've been able to do a whole lot, and I'm going to try to talk about that in 4 minutes. We've been able to co-design National Quality of Care Learning Platform. We also have technical support to Federal Ministry of Health and the National Primary Healthcare Development Agency. We've been able to develop the website, which is going to be a one-stop shop for RAMCA quality of care learning materials in the country. We've been able to support the ministry to reach out to 4,000 stakeholders of national and sub-national level and other country through multiple learning platforms. We are organizing a lot of webinars. We are having breakfast meetings, forums, and developing newsletters. Our newsletter is called The Boss. I don't know if you've seen it, but we have a newsletter called The Boss that is going around right now from Nigeria. We're also supporting the Federal Ministry of Health and other partners to implement quality of care in the country. We have developed a lot of policies, guidelines, supporting documents. We are implementing the RAMCA quality of care implementation plan or guide, which we have developed over the period. We have also developed the quality of care manual for the country so that in Nigeria, when we say quality of care, we are speaking on one page. So we have put together a quality of care manual for the country. We are also supporting academia to go on research for the country. We are also supporting about 12 new states, additional states right now as I speak, having advocacy visits, building their capacity on quality of care, creating or forming the technical working group for the states, and doing a whole lot for the states right now. There's so much to talk about, but for four minutes, for now, I'll stop here. That's a huge work we're doing in Nigeria. Thank you so much.
Yeah, thanks. It's one question I have for you, Dr. Ope, is like, you know, there's so much emphasis put on the external supervision visits rather than the type of internal problem solving and quality improvement work that you guys have been supporting. How have you been able to help subnational governments, you know, the subnational level, transition, you know, their funding and effort into supporting these facility level like quality improvement? Like, how do you feel you've been able to help them make that transition?
Okay, like I said earlier, we're working in the national and subnational level. And for the national level, we've been able to support the Federal Ministry of Health to work in with the technical working group. For MCGL Nigeria, we have not come to duplicate any effort. We are working with the existing structures. So the existing structures that we already have is the steering committee and then the technical working group, which we are working with in the national. And the technical working group is one of the high decision-taking body in Nigeria, where we have partners, we have state, subnational teams, representatives in that meeting. We're supporting that meeting to hold periodically for like twice a year. We've held like 4 meetings right now where we bring the subnationals together to showcase what they are doing, the progresses they've made so far, the concerns they are having in quality of care, and how to progress, how to go about implementation of quality of care. And for you to scale up in the subnational or in the state, you are expected to take permission from the technical working group for you to proceed. So we have also been supporting the Federal Ministry of Health to form technical working group for the states as well. So in the states where we work, we have been able to form their own technical working group. We have additional 12 states as I speak. Advocacies have been conducted. We are building their capacity right now, training them on quality of care. And we are also looking at how these states can also select learning sites we've been able to select, in support of Federal Ministry of Health, select the learning sites where they are going to showcase quality of care in their state. And these learning sites, we have also gone ahead to see how they can form the quality improvement teams in those learning sites. And we're supporting the states to see how the quality improvement teams can go about implementing projects for quality of care and doing what they have to do and they have to do it best. We are also supporting the states to also develop the operational plan for the state, which is going to be used to implement quality of care in the various learning sites. We are scaling up at the moment, but the scale up is gradual. It's we have a criteria for you to reach, for you to scale up to other health facilities. And such states that have been able to meet up with the criteria, they have been, at the moment, they are scaling up to other sites and then picking up other new sites where they can implement quality of care. There's a whole lot happening because of sustainability. We are looking at working with what they already have. We have the MPCDSR committees in the learning sites at the moment, and we're working on those learning, MPCDSR committees to also develop and create the quality improvement teams. So both committees will be looking at maternal mortality audit as they as well look at implementing quality of care projects in their health facilities. These health facility quality improvement teams are also managed by the facility management team or the quality improvement facility management team. They are supporting them, supervising them, and seeing how they can best implement quality of care. We have also conducted the baseline assessment in this learning sites so that by the time the project is closing out, we can say that this is where we were and this is how far we have gone and where we are at the moment. I don't know if I've taken too much of your time, but if you want me to come back, I can speak some more of what we are doing. But at the moment, we are doing so much in the subnational and the national in Nigeria. Thank you so much for having me.
Thanks, Dr. Ope. So I'm going to move on to Dr. Lilik next, but I love that, you know, it's wonderful to hear your illustration of how you're using existing national systems and structures to implement this work. It's really exciting. And I'm sure we'll come back to you with more questions. And please put questions you have for Dr. Ope in the chat. So I'm going to move to Indonesia now. We have Dr. Lilik is going to answer some questions for us about the work they're doing there. So Dr. Lilik, you know, you are the COP, of course, for the Momentum Private Healthcare Delivery Project, but also between MPHD and also Momentum Country and Global Leadership in Indonesia, you're supporting clinical mentorship combined with point of care quality improvement as a key strategy. So we'd love to hear from you a little bit more about what you're doing in Indonesia and what you feel is working well with this approach. So over to you.
Thank you, Julia. So yeah, I think Julia already mentioned about the history of hospital mentoring in Indonesia. And I think after like a decade from the first day we bring mentoring to Indonesia through JPIGO, through a mass project, the Ministry of Health now would like us to focus on improving quality of care. So that's, I think, the interesting like kind of turnaround from the ensuring the management of care into quality improvement. And it's a continuation of what the government doing with point of care quality improvement. So in doing that, both Momentum, MCGL and MPHD are start with the hospital mentoring, but we fill the hospital mentoring with a quality improvement model capacity strengthening. So it's about, you know, quality improvement model, PDSA, and that also embedded into all the daily activity at the clinic. So like the MPDSR at facility level, we put that into a quality improvement resource. So that's one thing. Also, also with the emergency drills that we do with hospital mentoring, it could be like the entry point for clinic to see their gaps and then doing a quality improvement process to that. So that's interesting because what we see in the momentum, in both momentum, we are bringing this culture of quality improvement to the health worker at the facility level, and we engage the quality team at facility level. Even though by accreditation, hospitals are mandated to have a quality team, but when we are doing this quality improvement, we saw that a capacity still need to be strengthened. So first, it's a as a culture, we need to do a repetition, doing the PDSA. And then the second thing, I think what we found interesting is that they need to see proof. They need to see evidence that what they are talking on the table are really helping them in their workplace. So that's something interesting that I observed in the hospital that we work with mentoring and quality improvement, is how we can help them see the evidence, and then coaching them or side by side with them, doing a repetition of PDAC. I think that's an important new things that we saw from mentoring during AMAS and today, and I think it's something that really because health workers see what changes in their workplace, and that's interesting, and not just about showing the data that something is changing, but they really feel that changing. So I think that's one point that I observed, Julia, and interesting to see that coming into an evidence.
What do you feel? So I'm hearing a couple things from you, the emergency drills being really valuable, but really giving health workers the control and ability to improve things within their facility as being like really impactful. Especially you talked about them feeling invested and seeing like active changes, because we know how hard their work environments are, right? They often, well, it's maybe a little better in Indonesia, but they often don't have what they need or work under very difficult conditions. So it's great to see that you're seeing that change. What do you, in addition to that, what do you feel is working particularly well about this combination, even an interesting combination of thoughtfully linking mentorship efforts to a facility-based QI intervention? You guys have brought that together very nicely. What do you feel works particularly well about that approach?
Well, it's like I don't know which one start first, but as you know, the like MPHD is particularly MPHD. We work with Directorate of Quality of Health Services, and the message for us is to improve maternal and newborn health. That's another directorate to be frankly speaking. So when we are talking with people from ministry, which is from Quality of Health Services Directorate, it's like bringing something new to them that they need to focus on MNH, but we bring the quality improvement theme more to to the surface, because that's our partner. So that's one thing, as I think it's a good opportunity to start with. The second thing is that with accreditation that already widely implemented in Indonesia, hospital are mandated to have a quality team, as I mentioned earlier. But really, there are lack of guidance, especially for private hospital, on how this team, the quality improvement team, have to really work. So hospital mentoring, which is a group of specialists and then also a quality expert come to hospital, is really like showing them how this quality team really need to work. So I think that's a good linkage between hospital mentoring and the what is it, the instrument that's already mandated to be there in hospital. So it's like giving a car a new gasoline to start with and running faster. So yeah, I think that's I think what really interesting on this.
Thanks. I like the link you're making between quality assurance through external supervision and accreditation, which lines up nicely with supportive supervision efforts, and quality improvement, making the changes happen like at the facility level. Thanks for that. I'm going to move to our next. Please post questions you have. I see there might be some questions in the chat. We'll get to them for Dr. Lilik. I'm going to move next to our team from Ghana. We've got two folks from Ghana, Salamatu and Eugenia. And Salamatu, I'm going to start with you. I understand you all are implementing a blended learning approach specific for LARCs. So blended learning is something that was identified as promising because it's not only digital content, but also like practical, skills practice. So talk to us a little bit about what you're doing with that and what you think about the effectiveness.
Hello, everyone. Thank you, Julia. As you already mentioned, the blended approach is a combination of the digital or the online bit and then also in person. We adopted this approach because it's kind of response to the needs of the private sector. The private sector is profit-oriented, and they cannot go the traditional way of pulling a health provider for a LAC training over a period of 2 weeks. So the blended approach actually responds to the need of the private sector. We don't want to put in measures to strengthen the private sector, at the same time also interfere with their clinic hours and all that. So this blended approach really responds to the needs of the private sector. We adopted the LAC training content from Ghana Health Service. My previous speakers also made mention of quality of care. You can see that quality of care was running throughout their presentation. So apart from the LAC content from Ghana Health Service that was adopted and then converted into a video tutorial for the online version, we also adopted the quality of care models from PSI. So we have person-centered care, we have introduction to emotional intelligence, and then a counseling approach that responds to the reproductive needs of the client, which is the C4C. Basically, with this blended approach, our training strategy looks at 3 main phases. First of all, you have the self-paced online learning. At a go, you can take the course for 2 hours, but then we allow the self-paced for a period of 2 weeks so that the provider can log on and then take the course. We did it in close collaboration with NMC, the Nurses and Midwives Council. So we make sure that at least we get the right cadre for the training. We all know IUD is very delicate. It's a very delicate procedure. So we make sure that we get the right cadre. Before you log on, you are supposed to have a valid PIN. That with NMC, that will give you access to the online learning bits. The online learning bits is structured in the way that it pulls the provider along. We don't want you to just run through the videos without actually taking your time to go through the course. So we decided that at least you should do a score of 70%, a minimum of 70% for you to qualify for the next phase. So we are able to pull them along. This 70% becomes like a prerequisite for you to sit in the in-person, which is the next phase. So with the in-person, you get the opportunity to practice on the pelvic model and then the arm model. And then you get the opportunity to also get some presentation on the quality of care models that we adopted. Then you move to the next phase, which is the mentee and the mentor approach. With this one, facilities are clustered and you have a mentor visiting the facilities. This approach has really been welcomed by the private facilities, or let me say the private owners, because in a way it is strengthening to make sure that they have the right cadre who will provide a broad method mix for family planning without interfering with their workspace. So basically, that is what we are doing in Ghana. We work closely with GPIGO. GPIGO controls the online bits, provides orientation for the providers on how to navigate the online bits. We work closely with Ghana Health Service, and we also work closely with the Nurses and Midwives Council. Thank you.
Thanks, Salamatu. So you were able to reduce the in-person requirement from 2 weeks to 1 week, right?
Yes.
And so about how much money does that save you per training?
Okay, so let me just cite an example. We have another
30
project
seconds or less.
we have another project that runs the traditional way of LAC training that looks at the 2 weeks residential training that cost about $21,000 for a class of 20. So certainly this has been reduced to 1 week in person. So it's about a half course of the traditional way of training providers for LAC training.
And what are you seeing, like very briefly, and then Eugenia, I have a question for you about engagement with the public sector and potential scalability. What are you seeing, Salamatu, as far as provider competence, like when they complete this? Like, is it, what do you see?
I can say that the providers, right from the self-paced online, you are supposed to make a mark of 70%. That becomes like a prerequisite. So this kind of pull the providers to become attached to the course to make sure that at least they get the mark. And then when you come to the in-person, you get more time because you have taken an online, a portion of the course already. You are allowed more time to practice on the model. And then our mentee and the mentor approach takes about 6 weeks. So we have logbooks that has been developed for you to log in the number of sections you do, which is more than the traditional one. So you have more time to do the insertions and then the removal. And you also tend to have a direct feedback from your mentor. So yes, we can positively say that our providers that we have trained under the blended approach have acquired a high level of competence for LAC service provision.
Thanks, Salamatu. And Eugenia, in the 2 minutes, I'm going to try to wrap it up in 2 minutes so we can take questions. I see some are coming in. Can you talk a little bit, you sit in both projects, what you think is relevant for the public sector and also the potential for scale?
All right, thank you very much. And so for the public sector, that is the MCGL in Ghana, we also adapted this blended approach into the training of 119 healthcare providers under the 82 zone of influence currently that MCGL works in. So just as Salamatu said, we also went through the online bets approach, and it was so welcoming. And looking at the scale up with what we did for the public sector, it really reduced time, and it's really brought out that bit of the digital bit of the training to these providers, because sometimes some of these healthcare providers do not really get access to these platforms, and this really gave them that opportunity to go onto the WCA app to access all these courses. And it's also, just as I said, also gave a lot of information, because it was a combination of videos and some very key content that they can read and on their own self-paced learn it before they even go into the in-person training. For the approach, it has been very great, especially at the public sector, because most of them within 2-4 hours, they were able to finish their online paced learning because of the excitement of this blended approach that we adapted from the MPHD. And looking at it, it also built some kind of a continuous relationship. So it's not just for nursing and midwives, but we also had some PAs, the some medical officers coming in, not just really for the nursing and the midwives, and also bringing other cadres to help with this online bit. So for the approach, for us as MCGL for the public sector, it has been great and it has been welcoming. And Ghana Health Service has also really supported that, looking at it as a new approach. Even though we use it for MPHD, MCGL, it was also welcomed and they flowed with us throughout the process.
Thanks, Eugenia. And I understand that CPD platform that you used is run by the NMC, and currently between that platform and the Medical Dental Council, they're reaching almost 90,000 health workers, right? So it's,
yes.
Yeah.
Yes. So currently, for the CPD for the nursing and midwifery, we have a total cost as it stands this morning, 850,000 courses. And where we have learners who are being registered on the course, they are about 120,000 currently using these courses. And when it comes to Medical and Dental Council, we have 2,039 courses on the Medical and Dental Council. And where learners, we have 1,016 with the Medical and Dental Council in Ghana, which we say that the platform is really doing great in Ghana with the help of NMC and all the stakeholders.
Yeah, and just to note, Aaron, from USAID's perspective, that 20 of the courses created under MCSP funding are currently housed on that platform and reaching across Ghana nationally. So that's exciting to be using a national platform. Thank you all so much for joining from everywhere. It was wonderful to hear your illustrations, and we're going to transition now to taking Q&A, and I'm going to try to respond to some in the chat. So Koki, over you to run our Q&A.
Well, thank you. And what a wonderful fireside chat. And I think some of the questions actually really make it look like a fireside chat because they're deep and provocative. But let's start. I think I'm glad, Julia, you have your camera on still, because I think there were a couple of questions that were directed to the presentation that you made at the beginning. One was like, what kind of evidence was used to find out the approaches? And then just linked to that, like you said, there was in one of your slides, the bottom two approaches, which said that they had neither evidence nor preference. And how did they end up on that list that you shared? So if you could respond to those.
Sure. So very quickly, and I responded briefly in the chat, but for the evidence, we pulled that from the desk review. And we heavily, like a lot of our evidence came from Alex Rowe's landmark literature review of interventions to improve health worker performance in low and middle income countries. From that lit review, that's a database and a lit review that he and other partners have been running for over the last decade. So there are quite a few lit reviews that evolved from that database that we used to summarize the evidence in where we had promising approaches. One of the most useful is a 2021 article that looked at evidence of impact over time after you stop investing. But, a lot of interesting things came out, but we pulled that and it specifically looked at evidence around change in practice outcomes, which is defined as change in either reduced consultation time or increased adherence to guidelines. So most of the evidence came from those lit reviews. And then I think I corrected in the Q&A, I misspoke. The two on the bottom had limited or promising evidence. We didn't put anything there that didn't have evidence and were preferred. So I think I said the wrong thing, but those were, there's limited evidence on mobile social, which was defined as using, messaging apps to support peer-to-peer or mentor-to-peer learning, but it's a preferred. So everything on that slide has some positive evidence or it wouldn't have shown up there. But yeah, I must have misspoke then. And I'll respond about the Alliance Working Group in the chat, Koki, in the interest of time.
Thank you. And then there were two, one comment and one question, which was linked to how most healthcare professionals face lack of career advancement, lack of training puts an end to their skill development and career growth, and the need to set performance goals often remains ignored. And so employees aren't aware of what is exactly expected of them. How can this be changed? I mean, these are really deep and important questions. And I think that as countries move towards setting up these addressing human resource challenges, we need better selection processes for how the healthcare workers are selected for where they are posted, and tailored training curricula for based on where they're posted, as well as designing appropriate career pathways, including appropriate incentives for being posted in hardship positions. I don't know, Julia or anybody else from the panel, if you want to add anything to these few sets of questions.
I took those as comments, but I just want to reinforce one of the things that I heard. Those are all great points about the need to be more rational. And one thing that was clear from the journey mapping is there's a lot of opportunity in the existing facility level HR processes that the vertical programs are trying to do, when really that's the role of HR management at the facility level, the lack of a standard orientation, the lack of really interactive annual appraisals. Like, so we saw that as a great missed opportunity. And that's something that came out of our long report that we didn't have time to get into. So back to you, and I'll try to respond to other questions in the chat.
Okay, thanks. And I have a couple of questions where maybe Comfort and Bulilik could weigh in. There's a question which says that I would like to hear how the healthcare worker learning strategies translate into high quality of care and high performance at the facility level. And linked to that, I think, was another question. Can you give examples of changes that healthcare workers themselves want to see and that they feel helps their work? So Comfort or Lilik, would you like to respond to, maybe just give your quick thoughts?
Yeah, thank you, Koki. So as simple as having this team of health workers to be together in one table is I think is very important start, because it's not every day that they can, you know, like sit together with the doctors, the nurse, the midwife, the administrator, to talk about, you know, same gaps. So I think I found that as one you know, change that they can directly feel, and then they can, you know, freely open and be honest about their problem. And I think that's a good start to next quality improvement and PDSA working. I think that's all my response, Koki.
Okay, and then Dr. Okpek, there are two specific questions for you, and you could also respond to these. One was that people were admiring the work that you've done, and that subnational level where all the action matters. However, are existing structures equipped to sustain quality of care once the project closes? And similarly, there was another question asking, like, how will we ensure the sustainability of the support provided in the coming days after our support ends? So if you could respond what you have put in place.
So thank you so much for that question. I'm going to try to answer the question. I think the questions are directing towards sustainability or quality of care in the subnational level. For us to have sustainability for quality of care is the reason why we're working with the existing structures. Like I tried to explain earlier, the leadership composition for quality of care is such that sustainability will not be an issue. The technical working group right now that we're supporting, we're hoping that when the project closes out, they are going to be able to carry on the good job that we are doing, because it's being supported by Federal Ministry of Health. And we're hoping that Federal Ministry of Health will take the leadership to call this meeting and bring the subnational together periodically to talk about quality of care. We are also building their capacity, training them on quality of care, developing the quality of care manual, the RAMCA manual, which is going to be used even when the project closes out, because the manual will be there for them to use and to refer to. We also have the implementation guide which has been developed, supported by Federal Ministry of Health. They are going to be using the implementation guide to go on with the good job they are doing on quality of care. And that's why we are also building the capacity of the facility QI teams to be able to implement projects. We've been able to also support them with dashboard where they are going to showcase what they are doing. In the training that we conduct, the commissioners for health, the directors for public health, DPRS, all the directors are present in those trainings so that they can support and supervise the health facilities. So after the project is out, they can follow up with the trainings, supervision, and then the baseline assessment tool that has been developed for the country will be used even when the project closes out, because the baseline tool is for them to use, and we're not going to take it away. So I'm sure that sustainability will not be an issue. And lastly, the website that we are developing is embedded in the Federal Ministry of Health website. That's a one-stop shop for everybody. If you want information on quality of care, you can go there. If you need training on quality of care, you can go to check on the website. So the website is there for them to use even when the project is out. Thank you.
Thank you. Thank you. That's really important to, invest it within the Ministry of Health and the website that anyone can go to beyond the life of the program as well. Dr. Salamatu, there's two questions for you. One was linked to how does the huge cost of internet and connectivity issues in Ghana affect the online training? And can you say a little bit more about the blended model and how it's supporting the person-centered care within 2 minutes, and then we'll wrap up.
Okay, so let me just go straight to the internet connectivity. GPIGO provides a token for the providers so they are able to take the online course. Usually they are supposed to take the course just for us to be sure that they've taken it, and then GPIGO does the reimbursement. On the person-centered care, providers are so excited about it because it's not just the usual LAC training. They are excited about the emotional intelligence bit, person-centered, and then especially the counseling for choice. This has improved their counseling services to a more client-centered approach. If you want to compare it to what happened previously, it's like a client walks in and then you start with the whole method. But then with C4C, you are able to start with the client's reproductive needs. And then when you start with the client's reproductive needs, you kind of respond to what they actually want for that particular method. So C4C, they are very excited about it. And we have managed to also get the buy-in of Ghana Health Service for the C4C. Yes, we scaled it up. We piloted it with the MPHD project, but we have Ghana Health Service buy-in for C4C. So currently we have been able at the national level to embed C4C onto the National Family Planning Protocol. And we are working with Ghana Health Service to scale up C4C in Ghana. So from MPHD, we have introduced a new counseling approach that the government or the public sector thinks that it is worth emulating in the public sector. We are currently giving them support to make sure that it is scaled up. So yes, the quality of care bits has gone from private to the public. Thank you.
Great to hear. And I just want to summarize. I'm sorry, we are running out of time, and our team is still answering questions in the chat, and we will have a recording of everything that was shared today for everyone who registered, so you can see the responses to the questions as well. But it is so clear from the presentations and the questions that there's a growing recognition that we can't keep doing the same thing and expect different results when it comes to strengthening health worker learning. And we need to make sure that we are collectively have more work to do on this global learning agenda, but there's both incredible interest in this subject and motivation to work in a way that brings change and impact for healthcare workers and the people that they care for. So today, I'd really like to thank our speakers, Erin, Julia, Dr. Lilik, Eugenia Salamatu, and Dr. Okpe for sharing their insights and being with us today for all of you to join so early in the morning and late at night for some. We will be sharing a full recording, as I said, and to all those who registered. So stay tuned, and thank you for your interest in this conversation. And we continue to work on supporting the healthcare workers that we work with. Thank you.